I'm Eva. I'm a third-year resident. I'm going to be doing my lecture on wound and ultrasounds we could do for them, thanks to the ultrasound team. So we're going to start off with the case. This is actually a case I saw in CCT with Dr. Z. We're going to discuss skin and soft tissue infections. We're going to discuss the sonographic features of them and understand when, why, and how to use an ultrasound in a wound evaluation. And then we're going to do questions. We're starting off with the case. So this was in CCT. We had a 56-year-old male. He had a history of diabetes. He wasn't on any medications. His chief complaint was altered mental status. He complained to us of shortness of breath, weakness, headache, but he was distressed. He was altered. He wasn't even able to provide us with the date of birth. He was only able to spell his name partially, but he did tell us that he didn't have a fever or chest pain. So these were his vitals. So he was pretty tacky. Obviously, he was a little hypertensive, but he was afebrile and he was saturating 100% on room air. And so this was actually the actual picture that's in the chart of what we saw in his leg. So he was tachycardic and he had a large area of redness and fluctuance in the left inguinal upper thigh region with no crepitus, but it was erythematous and it was very tender to palpation and it was very subtle on exam. This was a reminder of how it's really important to, do a full head to toe exam because we didn't really know what was going on exactly. So we did some labs. His white count was very elevated, but otherwise the CBC was fairly unremarkable. His platelet count was a little bit elevated. And then in terms of his comp, he had a glucose of 701. His bicarb was 8. His creatinine, we didn't have a previous, but it was 2.36. And then his anion gap was 41. And then this was his VBG. He was obviously very acidotic. His lactate was 6.9. So it was pointing towards a DKA. So we're going to take a quick break from the case. We're going to discuss the 3 big skin and soft tissue infections and the sono findings we see in those before we talk then about the case outcome. So necrotizing soft tissue infections, they're rapidly progressive infections. They primarily involve the fascia and the subcutaneous tissue. And then there's been an increased frequency of infections because there's an increase in immunocompromised patients with significant risk factors. Gas formation is not a requirement for the diagnosis, and even not having gas on imaging is also, you can't rule out necrotizing fasciitis just with that. It's obviously very severe. It's the most severe form of a soft tissue infection, and it's potentially limb and life-threatening. A big important point is that early recognition and aggressive debridement are major prognostic determinants, and delay increases mortality. So this is a score that we don't really use it very much, but it is the laboratory risk indicator for necrotizing fasciitis score. It's basically a clinical decision tool for distinguishing necrotizing fasciitis from other soft tissue infections. But there was a prospective validation study done in Taiwan in 2020 that showed the sensitivity of the score was poor. So it may not be the best tool. I feel like I've never used it in the ED before, but it is something to consider. So some risk factors for neck fash are diabetes, drug use, obesity, immunosuppression, recent surgery, and traumatic wounds. So other soft tissue, skin and soft tissue infections are also cellulitis. We see this a lot. It's basically acute spreading infection of the dermis and subcutaneous tissue causing overlying skin inflammation. Most often it's caused by strep or staph, including MRSA. Some risk factors include previous cellulitis, wound or current leg ulcers, excoriating skin diseases, lymphedema, venous insufficiency or obesity. And these rashes are often local. They're erythematous, they're warm, they have swelling, and they have tender and distinct margins. They can also have fever, chills, malaise, headache, nausea, vomiting. And then abscess as well, we do see this a lot. It's a localized collection of pus surrounded by inflamed tissue, usually caused by a bacterial infection. MRSA is one of the most common causes of this. And it's obviously very tender with surrounding induration and fluctuance. So I know there's a lot of people out there who may not agree with POCUS for skin and soft tissue infections, but physical exam alone can be misleading, like we saw with my example. So POCUS is a good way to basically differentiate between cellulitis, abscess, neck fash, and a rapid diagnosis can lead to better outcomes, especially in high-risk patients. So the probe we'd use is a linear probe. It's a higher frequency probe, and you use minimal pressure and you scan in two planes. So this is what normal anatomy looks like. The skin is hyperechoic, and then you have subcutaneous tissue, which has hypoechoic lobules. You have fascia, which is echogenic, and then muscle, which is striated. And then with neck fascia, the biggest thing is that you see basically just it's hyperechoic, and you also see air shadowing. The biggest takeaway from this lecture when I spoke to the ultrasound faculty is dirty air shadowing, and that's what you see in neck fascia. There was a study done. It was a meta-analysis done in 2023, which they basically analyzed POCUS in diagnosing neck fascia, and it was found to have a sensitivity of 88.2%, a specificity of 93.3%, a positive predictive value of 83.3, and a negative predictive value of 95.4% in regards to diagnosing neck fascia. So there were these two major studies done, STAFF and then SEFE. So STAFF was a subcutaneous thickening air fascial fluid. And then the other study was sonographic exploration, fascial exploration. So in this study, they had a case where the patient was 44. She was coming in with basically left lower extremity rash, and it was very painful. They used the score we had spoken about, and they used ultrasound findings as well as physical exam. And in this institution, the patient was immediately taken to the OR, and they didn't do a CT or MRI. So that's why, so they did a case study with this, and they decided that basically POCUS, if you use the acronym STAFF, it's subcutaneous thickening air and fascial fluid. It's a good way of remembering what you have to look out for. I think that would be a little bit unrealistic at our institution, obviously, but it just shows, like, you know, obviously getting the diagnosis quickly is important. So you don't want to exclude neck fascia on the basis of ultrasound, but it has been shown to be specific in soft tissue infections. And so that's why it's important to be able to use it. And then with the sonographic exploration for fascial exploration in neck fascia, they showed that basically you use CT scans with IV contrast to be able to focus on images. And a lot of them found focal subcutaneous fat infiltration and fascial thickening. But this lacks specificity because you could also see that in non-necrotizing infections and even in non-inflammatory conditions. So they spoke about how MRI is actually the gold standard, but obviously getting an MRI is like pretty unrealistic, I think, in, you know, quickly in most institutions, especially ours. But technically MRI is the gold standard because it has a sensitivity of 93% in detecting neck fascia. And so there's just been a lot of case studies that have shown that ultrasound can be very helpful and can be accurate. So in this study, they had this patient who basically they did transverse view of the posterior left lower extremity distal to the popliteal crease. And you can see that the fascia is indicated by the arrowhead. The anechoic fluids collection is noted anterior to the fascia, and deep to the fascial layer is a complex fluid collection with in the arrow with diffuse hyperechogenicity of the gastroc muscle. So cellulitis, again, I think obviously we've seen it before. You see cobblestoning, you have hypoechoic fluid between echogenic fat lobules. There's no discrete fluid collection, and there's mild fascial thickening is possible. But it's really important to remember that this can be present in lymphedema as well as pitting edema secondary to heart failure. And then with an abscess, you would see a fluid collection with posterior enhancement, anechoic and hypoechoic fluid collection with irregular borders, posterior acoustic enhancement, and it may contain swirling debris. So I wanted to go back to the case and what happened. So basically this patient was in DKA, obviously, and we thought the source of it was this neck fascia wound. So once we saw this, we threw an ultrasound on it, ultrasound probe on it, and we were able to see that they had signs of neck fascia. So we just very quickly now expedited getting a CT and getting SICU involved as well as MICU. We gave fluids, we gave antibiotics. So we gave vancomycin and clindamycin. But then it was this back and forth between SICU and MICU because essentially SICU didn't feel comfortable bringing him to the OR right away because he was obviously very sick and he was super tachycardic to the point where he was in AFib with RVR, and we consulted cardiology. because the ICUs wanted them involved at that point, and we gave amiodarone. But ultimately, SICU ended up taking the patient, which I think was better in the end. So then they were admitted to SICU. They underwent they basically were brought to the OR multiple times. They underwent an incision and drainage and debridement of the left lower extremity on day one, and then they returned to the OR the next day for additional debridement. They came again 3 days later for incision and drainage, as well as debridement of the left groin abscess, and then a day later for again debridement and washout, and then about 2 weeks later for a left groin wound closure. He was also anemic, so they gave a blood transfusion. They repeated it. He was initially anemic to 6.9. They gave him a unit, and then he was 7.5. So he was downgraded to floors after that. He was seen by PT, who recommended home health aide and home PT, and he was discharged. So I wanted to do some practice questions. So the first question is, a 32-year-old male with a history of IV drug use presents with localized discomfort in the right upper arm. An ultrasound of the area is shown below, but what's the most likely diagnosis? So the answer is a retained foreign body. So ultrasound, it has a sensitivity of over 90% in detecting soft tissue foreign bodies such as wood, metal, and plastic greater than 4 to 5 millimeters in length. Lower frequency probes are able to detect foreign bodies at a greater depth, whereas higher frequency probes are better for more superficial foreign bodies. And they're usually hyperechoic with acoustic shadowing extending distally. If there's a hyperechoic rim or a halo sign is what they call it, there could be a surrounding abscess. And then we'll do the next question. So the answer is, so basically let me just go back to the question. So the high frequency ultrasound transducers, they're better at detecting shallow foreign bodies, and they have the highest image resolution. These can often be missed by conventional radiography, so that's why it's a great thing to use. And they allow for greater resolution of the image. And then we'll do the next question. So this is a 45-year-old male. He has a history of diabetes. He's coming in with left leg pain. He's tacky. He has like a bit of a soft blood pressure, and he's febrile. He has a tender lower extremity with erythema and warmth. He has crepitus on palpation. So this one's obviously very easy. We use broad spectrum antibiotics, and we also consult surgery, something that's super important. So we use I wasn't really sure why we used Zosyn, Vanco, and Clinda with my case. And I was looking it up. We use clindamycin also for its antitoxin effects. But you want to be really aggressive and make sure you get surgery involved right away, because surgery is the definitive treatment. And apparently administration of antibiotics alone is associated with a mortality that nears 100%. So it is important to give antibiotics, but really the most important thing is surgery. And then here's the next question. So you have a 27-year-old male. They're presenting with right thigh pain. They were noted to have a 5-centimeter patch of erythema and warmth in his anterior thigh yesterday, not associated with fever or nausea. Their glucose is 250. This is the ultrasound. What's the next step? So the answer is you want to discharge with oral Bactrim. This is a little bit controversial though, because Bactrim doesn't have, this is a Roche review question, but when it was being reviewed by the team, they talked about how Bactrim doesn't have the best strep coverage. So that is something to consider. But yeah, as we know that when you do an ultrasound of cellulitis, they'll have cobblestoning, and they have the hypoechoic edema distributed throughout the superficial skin tissue and subcutaneous fat. And then this is the next question. So it's a 21-year-old male. He's coming in with right thigh pain after being struck in the thigh with a helmet during football practice. He noticed he's had significant pain and swelling, significant pain with passive flexion and extension of the knee, and he's requiring increasing doses of pain meds. He has good distal pulses without delayed cap refill. The x-rays are negative for a fracture. And so what would the next step be? So this is actually compartment syndrome. So you want to emergently consult orthopedics. So compartment syndrome is a clinical diagnosis, but you want to look at the delta pressure. So it's the diastolic pressure minus the compartment pressure. And it's obviously it's a limb-threatening condition that is resulting from increased pressure within a muscular compartment, which is causing compression of the nerves, muscles, and vessels within the compartment. And the pain is going to be disproportionate to the injury or the physical findings. So the key takeaways for this is you want to scan in 2 planes. You want to do minimal pressure. You want to have a high index of suspicion for high-risk patients. Like with my DKA patient, we were trying for the longest time to figure out what's going on, what's causing this infection, what's causing him to be so acidotic. And eventually we did like a full head-to-toe exam. And, I mean, he ended up being fine, but I wonder if we had done that sooner, if we would have, been able to figure it out sooner. And then the biggest thing is dirty air shadowing. Any questions?